On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Robert Harper. Dr. Robert Harper is a board-certified orthopedic surgeon with extensive fellowship training in spine surgery.
Stat team, room 386. Stat team, room 386.
Dr. Harper is highly skilled in treating a broad range of conditions in the back, neck, and spine using the latest surgical methods available. This expertise includes the latest techniques in minimally invasive spine surgery, such as image-guided surgery. He sees patients at Boulder Center for Orthopedics and Spine in Boulder and Broomfield. Welcome, Dr. Harper.
Good evening, everybody. I'm Dr. Robert Harper. I am a fellowship-trained, board-certified orthopedic spine surgeon. What that means for those who don't know is I trained initially in orthopedic surgery during my residency, so I learned all the stuff, hips, knees, and spine. And then I did a special year of fellowship specifically devoted just to spine surgery. I want to thank everybody for coming out tonight. Tonight we're going to talk about the cervical spine, which is the neck from about the skull to the top of the shoulders. We did a talk on the low back before, and I would say certainly after the low back, this is the most common reason that I see people in the clinic. To start off tonight, I'd like to start off with a little bit about the anatomy.
Stat team, room 386. Stat team, room 386.
Luckily, I don't have to go there. We'll start off with a little bit about the anatomy of the neck, and I think it's important to go through some of this to have an understanding of why your neck hurts or your arm hurts or your legs feel funny. And then it also is important to discuss some of the treatments that we use for some of these painful cervical conditions. The cervical spine is made up of 7 bones, starting at C1 through C7. And unique to the cervical spine, up here at the top, you have C1 and C2. And C1 is like a ring, and C2 has a little spindle around which C1 rotates. And that's where 60% of the rotation of your neck occurs at C1 and C2. And at the top, what we call the atlas in the axis is C1, and on your occipital cervical joint is where your skull meets C1, and about 60% of your up and down motion occurs there. If you look to this image on the left, you can see the joints back here. This is looking at the back of the neck. And really each joint forms almost a shingle, wherein a little bit of the bone overhangs the bone below it, and that's filled with cartilage. This is looking at it from the front. This is the C1 ring, and this is the C2 that extends up into that so that this can rotate around the rest of the neck. You can see here, these are where the discs lie, and you have a large artery that runs through here on both sides. And we'll discuss a little bit of the neurovascular anatomy. And then looking at this side image, you can see the vertebral bodies here in the front, C1, C2, and then this is 3, 4, 5, 6, and 7. And this gives you a side view of how this shingle overhang of the joints is, which contributes to some of the unique motion of the neck and also some of the unique problems of the neck. Also important to look at is the muscular anatomy of the neck. And now there's a lot of muscles here, and we're not going to go into each and every one. The reason I brought up this slide is just to illustrate that not only, if you look at here on the left, the neck muscles really start often in the mid-thoracic spine, and so oftentimes you can have upper back pain that really has a neck origin, but that you also have many layers of neck muscles throughout the neck, starting from the outside, which is your trapezius, which is what people traditionally think of, all the way down to some of the smaller extensor muscles of the neck. And then really, if any one of these is becoming symptomatic, whether that through muscle spasm or torticollis or any other problem, it can really cause a lot of problems. And then importantly too here is the neurovascular anatomy of the neck. If you look at this image here on the left, this is looking at the front of the neck. If we're looking directly at it, you can see that artery that I discussed here. This is called your vertebral artery. This is an important blood supply to the posterior aspect of your brain. And then at each level here, you can see these yellow things. Those are the spinal nerve roots. Well, all of the nerves that go to your hands as well as to the back of your head come out of the neck. And so we'll discuss some of the pathology of those nerves as they get pinched. If you look here at the side too, you can see how these nerves exit out of the spine. There's a little hole on the side that we call the foramen, and those nerves exit each foramen. And if any one of these nerve holes has some sort of pathology, whether through disc herniation or some kind of bone spur, well, you can see how that might cause problems. And we'll kind of discuss the pathogenesis of some of those problems and the manifestations of those. And then a really important consideration when looking at the cervical spine, this is an MRI of the neck looking from the side. This is the front, the back, top, and the bottom. And those of you who have been in my clinic know this is kind of the speech that I give. This is C2, 3, 4, 5, 6, 7, T1, T2. Those are the discs in between, but the most important thing is this big, long gray thing. That's your spinal cord. This is the bottom of your brain and your spinal cord. And the fact that you have the presence of a spinal cord in the neck versus just a bunch of nerves like the lumbar spine adds an additional level of importance and/or urgency to cervical spine problems often. First problem we'll address today is neck pain. So neck pain is very common. It's almost as common as low back pain. This may be pain on the side of the neck. It may run right down the center. You may have pain that radiates out to your shoulders. It may occur when you bend your head down or extend your head up, turn your head one way or the other. It may cause your head to turn one way or the other. This is a really common condition, and it has so many origins, and we'll go into a couple of the most common reasons. This may be related to arthritis, muscle spasm, or even pinching of the nerves. And frequently you'll see if it's related to arthritis, it may be on just one side of the neck, or if it's muscle spasm, it may be just another side of the neck. Or it may extend all the way down to the mid-back, like I discussed before, because some of the muscles reach down so far. Back to this picture of the origin of the muscles in the neck, and the reason I bring this up is muscle spasm is an incredibly common cause of neck pain. This large muscle that you see here is called your trapezius, and that's what the muscle that you see that extends like a triangle out to your shoulder. And I would say probably 95% of the patients that I see in a cervical spine patient visit have some kind of trapezial neck pain. And that has a number of origins, and it could be from the facet arthritis, or even nerve pinching could cause that. But just good old-fashioned spasm of the trapezius is very common because we use the trapezius to elevate our shoulders. And I don't know if you guys are like I am, but I spend all day like this, just thinking and tensing and not really knowing that I need to just relax my shoulders a little bit. Well, constant muscle tension can cause muscle spasm. In addition, if you look a little deeper here on the picture on the right, you see a lot of the muscles that extend or are adjacent to the spine in lower levels, and there's a lot of them, the semispinalis, the splenius, and not to go into all of them, but if any one of those acts up, those are the muscles that help turn your head this way or look straight up or turn your head to the right or left. A small spasm in even one of these small muscles can really be quite painful. Torticollis is another cause of severe neck pain, and that's spasm of this muscle called your sternocleidomastoid, which attaches back here and comes to the front of your neck. And that really can cause a spasm of your neck that really causes, we call it wry neck was the old term for it. And that can cause a spasmodic turning of the head and really painful movement of the head, both back and forth as well as to the left or the right. Treatment of muscle spasm is varied and different. I would say in our clinic, this is certainly a non-operative condition, and the first place we start with literally everything in the clinic is physical therapy. Physical therapy to work on your neck stretching, your strengthening, your range of motion. There's an adjunct treatment called dry needling where they literally stick small needles into the muscle fibers of the neck on either side or in the back. This is an excellent treatment to relieve neck spasm. It breaks up all those adhesions of the muscle fibers where they're tensed and have created those knots that you feel. Massage therapy is a wonderful treatment of this. It requires a lot of kneading and moving out of those knots, but I know I've certainly benefited from when somebody's able to knead those knots out of my neck. And then Botox is actually an excellent treatment for some really pathological spasmodic conditions. That torticollis condition I was talking about, Botox for that does an excellent job of relieving those spasms because the toxin within Botox blocks the muscle transmission, the molecule transmission that causes muscle firing, and so can relieve the spasm in those neck. They can also do it into the deep and anterior and posterior scalene muscles. And that really can free up the neck to move around. In addition, they'll use neck dry needling and Botox injections for people that get chronic migraines because muscle tension in the back of the neck can radiate up around the back of the head like this and cause severe pain. And just by injecting Botox into the back of the neck, you can relieve those muscle tension, and that relieves headaches as well. A really, really common cause is facet arthritis. Now, facet is the word that we use for the joints in the neck. If you look at these pictures here, these are the ones that I brought up before. The image to the left is looking at your neck from the side. This is C1 and C2, 3, 4, 5, 6, 7. And this structure back here are the joints you're looking at from the side. And you can see, like we discussed before, they have this diagonal orientation. And they work like shingles. As they move back and forth, you flex, the shingle uncovers a bit, you extend, the shingle compresses. As you turn your head, the shingles do move side to side. Well, arthritis in the neck can be especially problematic because, you get arthritis in your knee, you can stop using your knee, you can get your knee replaced. You get arthritis in your shoulder, you can stop using your shoulder, you get your shoulder replaced. It's different in the neck because you have 2 joints for every vertebral segment. So you have 14 joints just in the neck alone. And if any one of those gets arthritic, which is a catch-all term that we use to describe loss of cartilage, bone-on-bone wearing, and then the itis, which is the Greek for irritation or inflammation, there's an inflammatory component too. And neck arthritis from facet arthritis can cause severe pain when you're trying to turn your head, when you try to look up, when you try to move your head back or forth. It can cause pain that runs up down this side of the head. Sometimes people get severe headaches that runs up and down the back of the head. They'll get pain across what we call the cervical-thoracic junction, which is this area here, because the joints at that segment at C7, T1 or T1, T2, that's an area of transition where you go from a lordotic neck to a kyphotic spine, and that is an area that experiences a lot of wear. A lot of times too, people experience some referred pain from this. They might have pain that extends down into the shoulder blades or pain that extends out into the shoulder. Just like we discussed before, physical therapy is really the first place we start. We also try NSAIDs, so that includes Aleve, ibuprofen, the prescription strength called meloxicam or Celebrex that do a wonderful job of treating the inflammatory component of the pain. Physical therapy, same thing, to work on the gliding of those joints. Generally, pain from arthritis is the kind of pain and stiffness you feel early in the morning. And you'll wake up in the morning, you'll experience stiffness somewhere, you move around, and in about a half an hour you feel better. That's usually how I know somebody has arthritis. Usually conditions that don't feel like they loosen up over time is usually it has a different origin. Same thing with dry needling and massage. There tends to be a lot of muscle spasm around the joints that tend to be extra irritated, and so dry needling and massage can really help with this. Chiropractic treatment works on the gliding of the joints. In addition, I wanted to talk about another treatment for facet arthritis called radiofrequency ablation. I'm sure a lot of you have heard of this already. Some of you may have even had this done in either your neck or specifically the low back. And that's if you look at this picture here, it's a picture of your neck from the side. And in the anterior portion, or the front here, you see the vertebral bodies. And these yellow things are the nerves exiting each level. Well, you can see coming off each nerve is a nerve that runs to the back, and it sits on top of that joint. That's the nerve that goes to the joint. And each joint has a nerve that experiences proprioception, which is where it can tell the joint is in its space. And also that's the nerve that transmits pain from the joint back to your brain. Well, a treatment called radiofrequency ablation involves 2 test injections where one of our physiatrists will inject that nerve with local anesthetic. And if you get a significant response, meaning that you have significant reduction in pain, over the course of the next day, that injection is repeated. And if once again you get a significant response in terms of reduction in pain after injecting that joint, they can actually put a radiofrequency needle, this large needle here, and put radiofrequency pulse through there to burn the nerve. It sounds brutal when I discuss it that way, but it actually is a wonderful and durable procedure for neck arthritis. And the good news is the nerve does grow back, and so it's not like a permanent solution. It certainly doesn't cause any motor issues. It does provide an excellent response to neck arthritis. So moving on to one of the neurological conditions that we see a lot, and this is called cervical radiculopathy. This is sort of sciatica of the neck, if you will. And just like sciatica is pain, the nerve pain that extends from your back down your leg, cervical radiculopathy is the word that we use for pain, tingling, or weakness that extends from the neck all the way down the arm. And this may be when you turn your head in a certain way. It may have been after some kind of trauma or event. It may have been after you woke up in a strange way. I've seen really basically every single presentation of cervical radiculopathy that you imagine. But the one commonality from it is that there's an electric-like sensation, pain, tingling, or weakness that travels from the neck down the arm. It goes often to the hand or the fingers, or sometimes just out to the shoulder. Same thing like I described before in terms of referred pain under the long muscles of the neck. Not only do you get pain that extends all the way down the arm to certain portions of the hand, but people often experience things like shoulder blade pain or center of the back pain. Because if you take a triangle from my back and extend from here down to here, but in the back, that's the most common triangle of referred pain, including the shoulder blades and down to the middle of the back, from the cervical spine. And in fact, frequently when people come to my clinic and say, I have pain right here, it's got to be my thoracic spine, it generally is actually the cervical spine, because that's such a common area of referred pain from the cervical spine. That is, unless people have a fracture or something. And what is cervical radiculopathy, or what is the origin? Well, like I mentioned before, this is the spinal cord here, but at each level you have a nerve root that exits, and you have a disc adjacent to it. And I'll show you a picture next that kind of describes this a little more in detail. But really, whether that be through a disc herniation, whether that be from a bone spur, or that be from severe arthritis, somehow that nerve gets pinched as it is coming out of the spinal canal. And that's the nerves that come from the neck, from C5, C6, C7, C8, and T1, all come from the neck and extend down to the hand. And I'll show you a picture in a little bit, but we can often tell just by listening to you and telling us where your pain is or where your tingling is, exactly where the pathology is going to be. The symptoms of compression of a nerve root vary from pain that shoots down the arm to numbness and tingling, say maybe in these fingers or just these fingers. A lot of times when I see people in my clinic, it's for weakness. Sometimes people can't lift something, or they can't extend their arm against gravity, or they have trouble lifting their arm. That's weakness. That means nerve pinching is so severe it's causing weakness. Now this picture kind of illustrates exactly how this manifests. This is actually a cross section through here. So this is the front, back, right, and left. And if you look here, that's the vertebral body and the disc. This is the joint in the back, and this is your spinal cord. And coming off here are the nerve roots on both sides. Well, down here is an illustrative picture showing what a disc herniation would look like. And the nerve, rather than different than the back where it comes straight out the side, the nerve in the cervical spine comes from the spinal cord and goes forward, actually. It goes in front and comes out the front of the neck. Well, that's an area of weakness here where the disc is. And if a piece of disc herniates either back into the canal here or out into what we call the foramen, which is the nerve hole, it can pinch that nerve severely and cause severe weakness. This is showing where the disc herniates off to the side and where the nerve exits. Now this picture over here is what we call a dermatomal picture. And a dermatome is an area on the skin, or a myotome is an area in the muscle that corresponds to a cervical nerve root. This is just a general guideline because unfortunately not everybody reads a textbook. And honestly, you're allowed to have symptoms wherever you're darn well pleased, but I'll say generally this is around C6, this is usually C7, this is usually C8, and this is usually C5. And that's generally how we get an idea of where the basic pathology is going to be. That said, I've seen people with compression at C5-6, excuse me, and have only tricep weakness, or at C6-7 and have only finger numbness. And then if you experience weakness in different areas, C5 generally controls your deltoid and also part of your bicep. Your bicep is often C6, as is wrist extension. Your tricep is C7, and then C8 and T1 control your hand intrinsic muscles and your grip. And so if you have numbness and tingling in a certain area or weakness in a certain area, we can usually identify where the pathology likely is before we get the MRI. That said, when I see you in a clinic and you tell me that these are my symptoms, I have pain that goes down my arm, I have numbness and tingling in this finger as well as my thumb, I have weakness with my bicep, I'm assuming it's C5-6 because that's where the C6 nerve root exits, but I've also seen people with C4-5 symptoms. And usually at that visit, especially if you have weakness, I'll get an MRI right away. Now, generally, cervical radiculopathy is like any kind of disc herniation, and most of the time it gets better all by itself. And in fact, if you have just pain and numbness without weakness, it's okay to follow these things. And so usually the first line treatment is physical therapy. We try ice and heat, usually ice when it first starts and heat later because there's a lot of muscle spasm that goes along with cervical radiculopathy because the nerves that exit here that come off that nerve root also go to the posterior muscles of the neck, and that can cause those muscles to spasm quite a bit. And so even if you have just a single nerve root, I've seen somebody with C7 weakness, for instance. This person had severe tricep weakness, but pain all the way down the back of the arm and all the way up the side of the neck. And that's because the nerves that come out of the neck also go to those posterior muscles. There's a medication called gabapentin that we often use to slow down nerve conduction that helps with that severe nerve pain and tingling. I'll often, when I see somebody in clinic and they have severe radiculopathy in the arm, I'll often start with a Medrol dose pack, which is a small course of steroids over 6 days that helps suppress that acute inflammatory phase, because the presence of disc outside of the disc area is inflammatory. And so there's an inflammatory component to all the pain in radiculopathy and in nerve compression. And then when pain gets severe and it's not responsive to physical therapy, the NSAIDs, dry needling, gabapentin, oral steroids, we can do epidural steroid injections. So an epidural steroid injection is either when they inject, one of our physiatrists injects steroid through these spinous processes to the back of the, this will probably be a better picture of it, through the back of the neck into here, what's called the epidural space, that's the spinal cord, and inject steroid in that area. Or you can do what's called a transforaminal injection, where they inject steroid right here to where the nerve exits. That can often really help that nerve feel a lot better. I would say 90% of the time, this takes care of the problem and it doesn't come back. There are times where people do need surgery. The times where we discuss surgery are if you've had months of cervical radiculopathy that's been unresponsive to conservative care. And that means you've tried injections, you've tried physical therapy for over 6 weeks, you've tried NSAIDs, oral steroids, and gabapentin, and nothing seems to be working. We can usually fix this in one of two ways. Well, multiple ways, but one of two ways that is the most common. In addition, if you come to clinic and you have pretty severe weakness, if it's early in the game, you can sometimes observe this, but most of the time when people have significant weakness, we start talking surgery sooner rather than later. And the reason we do that is the longer something's weak, the less likely it is to return if you let that go. And so it's one of the few times in clinic where I discuss with somebody, hey, maybe we should talk about fixing this sooner rather than later, because I wouldn't want you to have bicep weakness or tricep weakness for a long period of time. This is an MRI of a patient that I did a surgery on, and right here in the middle is the side view of the neck. So that's the bottom of the brain, that's the spinal cord, that's C2, 3, 4, 5, 6, 7. And this is the spinal cord. And this person has a condition called congenital canal stenosis. And that means that at baseline, this person's canal is narrower than average. And so that means the spine really can't take a joke. And that means even a small amount of compression that might otherwise be asymptomatic in somebody else was symptomatic in this person. Although if you look at this image over here, if you see this large finger-like projection, you can see that's a pretty darn large disc herniation that this patient had. This is what's called an axial image, and that's a cross-section right through here. This is the front, back, right, and left. And this is an epidural vein, but over here, this big finger-like projection is a disc herniation, and that's putting pressure on this nerve here. Well, this patient had severe tricep weakness and severe pain. And really, after a long discussion and a lot of conservative treatment, we decided to proceed with surgery. The way we fix this is often twofold. Generally for single level radiculopathy or disc herniation, or even just foraminal stenosis, meaning narrowing of the foramen, an anterior procedure tends to work the best. And unless there's a reason that we can't go into the front of the neck, we usually prefer to go to this way. One, because the recovery is so much easier than going through the back of the neck. Now, there are times we have to go through the back of the neck. The morbidity of the surgery is so much lower. And the best way to get to this piece of disc is not through the back, but through the front. And so you dissect through the front of the neck, and if you see this interval that I'm pointing at here, this is my trachea, and this is my sternocleidomastoid, and this space here will take me straight down to the spine. And believe it or not, with just a small incision and basically moving my finger, you can get right down to the front of the spine. Because this patient had a fair amount of osteophyte, meaning bone spurs on the front of the neck, despite the fact that the patient was fairly young, I discussed doing an ACDF, which is an anterior cervical discectomy infusion. And the reason that I did that, and I'll discuss a little bit about that, is you can either do an anterior cervical discectomy infusion, or you can do a disc replacement. If there's a lot of bony spurring, if the patient has a lot of posterior neck arthritis, or some reason that you think that a lot of bone will form after the surgery, you don't want to put a disc replacement in there, because either the disc replacement will fuse up, or you'll preserve motion at an arthritic disc. In this case, I go through the front of the neck, I take the entire disc out. By coming through here, I take this entire disc out, and then I can take the disc herniation out from the front, make sure the nerve canal, and specifically this nerve hole, are wide open, and then I put this spacer in there to open the space back up, and then a plate and screw goes on the front. This patient woke up with no more arm pain, and the weakness got better. Frequently, the pain and the weakness will get better pretty darn fast. In fact, the order in which things improve tend to be pain, weakness, then numbness and tingling. Now, this patient had a very similar problem. This is C2, 3, 4, 5, 6, 7. And if you look here, there's a large disc bulging here. Now, this patient had disc bulging at other levels, but no symptoms at those levels. In fact, this patient very specifically had right tricep weakness as well as numbness and tingling. And because this numbness and tingling and weakness didn't get better with conservative care, but the patient had no large osteophytes on the front of the neck, meaning no big bone spurs, no signs of neck arthritis in the back, and no indication that this would quickly degenerate, I performed what's called a cervical disc arthroplasty. And if you look here on the side of the neck here, this is C6 and C7, this piece of plastic and ceramic here is the disc arthroplasty. And so rather than put in a static spacer of plastic with bone graft that goes through it, I put in a piece of plastic with titanium end plates and a ceramic ball around which to articulate, and this preserves motion of the neck at that segment. The reason we do this is, one, to preserve motion in the neck for younger patients, and there is some thought that it would protect the adjacent levels, because if you're fusing neck levels, you do put higher stress at additional levels. The data on this is varied. Some studies show that there's no difference, and some studies show that there's a benefit to cervical disc arthroplasty. In general, for younger patients or patients that really are concerned about preserving motion in the neck, this is an excellent procedure that I offer. In both cases, I do the surgery. The patient stays overnight for one night because I keep a drain in place, and in both cases, the patients go home the next day. This is a condition called cervical myelopathy. So when I discuss that there's a spinal cord in the neck, and that often increases the severity and or urgency and or severity of problems within the neck, this is the condition that I'm talking about. So cervical myelopathy is severe cervical cord compression, which is generally due to degenerative change. This is a picture of somebody's neck. That's C2, 3, 4, 5, 6, 7. This is the spinal cord, and I think you can see here that spinal cord is incredibly pinched at those levels. This usually isn't a traumatic event. In fact, it's basically a chronic spinal cord injury, and that's where the discs degenerate. You get osteophyte and or bone spur formation where the joints are, and you get slow, severe compression of the spinal cord over time, such that it even damages the spinal cord because it starves it of oxygen. Generally, this occurs slowly over time, and sometimes people have such a slow deterioration of function that they don't notice until it starts to get bad, and then it tends to occur very rapidly in stepwise fashion. So somebody may have a long, insidious presentation of this and all of a sudden develop hand numbness or leg weakness or trouble walking. Some of the manifestations of this are a difficulty with balance. Sometimes people say they feel drunk, but they're not drunk. A lot of times we blame balance or gait issues on the fact that people might be older, over 60, over 70. There's really no specific reason you should have gait or balance issues over time. And if I see somebody in my clinic, even if it's for a lumbar issue and they describe a balance issue, I always get a cervical spine MRI. And I'll say frequently, I find this condition has occurred. And the problem is it occurs so slowly and so insidiously that the analogy I use is the analogy of if you take a frog and put it in water and turn the heat up on the water, it will never know that the water heated up to boiling. And so this is very similar to that respect, because the balance issues become so insidious that maybe 2 years ago, you just felt a little unsteady in your feet, but you didn't think about it. And 2 years later, you're falling down every other day, and you just didn't really see there was no sharp transition of those things. And so all of a sudden you find that you're grossly unsteady, but there was no acute event that could describe those things. A lot of times people have trouble with numbness and tingling in the hands. They'll have trouble with hand dexterity or buttoning buttons, fine motor tasks. A lot of times when people get extremity numbness, they'll get numbness and tingling in the legs as well. Sometimes people will get bladder incontinence issues. What I'll see in my exam is hyperreflexia. So especially as we get older, our reflexes diminish over time. Well, if I see somebody and I tap their patella and they kick me in the face, well, then that's a little bit hyper. And so I assume that perhaps there's a pathological reflex going on. And then a lot of times this is accompanied by weakness, both of the arms and of the legs. This is another condition that most of the time when I see this in the clinic, I'm recommending surgery. And the reason I do that is this. cervical myelopathy, the analogy given to me by one of my mentors was that it's an elevator that only goes down. Once you've pinched the spinal cord and the pinching becomes severe, that becomes a bell you can't unring. So you've already incurred spinal cord damage. The best thing to do is very quickly get the pressure off the spinal cord and either solidly fuse that segment, or sometimes you can do a disc replacement to stop the pressure, because any decline that you get in function or any problem that you have, there's a chance that that can't be undone. Traditionally, mild disease, which was mild gait imbalance and maybe hyperreflexia, was followed conservatively, where we would follow this over time with serial MRIs and serial exams. The new thinking is to fix this sooner rather than later. And they've done both cost-benefit analysis, quality of life year analysis, and other analysis to determine maybe it's better to fix this later, because if you wait till it gets bad, then the amount of disability you have becomes severe. And I'll just speak personally, if I had something like this, I would fix it ASAP, because each level of decline that you get is potentially something you can't get back. Mild disease, you can often even rewind a little bit, where people find they have hand numbness and tingling. Even gait and balance issues will often improve, not always, but they will often improve if you catch it mild. When things get to be moderate or severe, your goal really is just to stop it from getting any worse. And so that's the general goal of this, is you're really trying to keep this from progressing and getting worse. But like I said, some patients do tend to improve. We treat this in a variety of ways because this tends to occur at multiple levels in the neck. ACDF, like I mentioned, if it's only 1 or 2 levels, you can fix it with ACDF. If it's multiple levels and you have severe cord compression at multiple levels, a lot of times we have to go through the back of the neck, take the shingles down of the back of the neck and open the spinal cord that way and fuse that. There's a condition also called a laminoplasty that I'll bring up here. So this is the ACDF procedure. This is showing the incision here, where you're taking out the disc from the front, relieving the compression from the front. And if the compression of the neck is in the front, then a lot of times we want to remove the pressure from the front, so a anterior procedure is best. Sometimes the pressure is in the back, and this is the shingle of the spine here. Well, you put these screws in the side, and if you basically cut this out and remove the shingle, basically almost like a lobster tail, and expose the back of the spinal cord to relieve all that pressure, and you fuse it into place. And then sometimes for younger people with no significant neck arthritis, or have a condition called ossification of the posterior longitudinal ligament, which is a fancy word for saying some of the neck tissue has become bone and causes severe cord compression, you can basically open the door of the back of the neck. You make a trough down one side of the neck, open it up like this, and you put plates in just to open, relieve pressure. It's a good motion preserving procedure. I have a couple of surgeries to show you that I did for these conditions. So this first patient was young, but had developed rather acute numbness and tingling in both hands, as well as severe pain on the arms and weakness. When I got this MRI, it showed severe cord compression here at C5-6 and C6-7. And this patient had weakness in both bicep and in tricep. Well, because the pressure was mostly in the front and not really in the back, and this person also had congenital canal stenosis, I opted to treat this from the front. And again, this it's such a good recovery in terms of pain, in terms of time in the hospital, in terms of overall function after surgery, that you go through, you take this off, and in fact, this person's arm weakness and pain and numbness got immediately better. And this is what the surgery looks like after you're done. Those are the spacers in there, and that's the plate holding everything in place. This next patient really had a much bigger problem because they had this cervical surgery, 15 years ago. And the person who did the surgery did an excellent job of getting these spacers in, getting the space fused up. But over the years, the patient had developed a lot of degeneration here at C4-5 as well as C3-4. And because those levels had degenerated so badly, this patient developed a spondylolisthesis where the spine had slipped forward because of arthritis of the joints and degenerative disc disease. That caused severe pinching right here of the spinal cord. You can see here at C3-4 and C4-5, the cord pinching was severe, and this patient had numbness and tingling in their arms, in their legs, incontinence issues, balance issues. Really, it was getting bad, and it was getting bad fast. This is one of those times where sometimes you have to do a bigger surgery, and so in order to reduce the spondylolisthesis, meaning put that back, elevate the space, and restore the alignment of the neck, I put spacers in through the front. But because the patient also had hand tingling as well as pinching down here at the bottom of the construct, I had to add some posterior instrumentation to open up that bottom level. And I will say, I just saw this patient, and actually they're doing very well at this point in terms of recovering with arm strength, numbness and tingling, even incontinence issues have gotten much better. This last slide is just to illustrate that the reason why we do this to keep things from getting worse, because if you look at the image on the left, that's preoperative. This is not my patient. This is from a talk I had given earlier. But to show you that here on the right, this is the spinal cord, and this person has had the surgery to relieve that pressure. Well, you can still see right here, that bright spot there is damage to the spinal cord, and that's irreversible. And that's why usually with this kind of condition, we try to get in, get it taken care of, and treat it as fast as possible. That's all I have for common spinal conditions today. Thank you very much for all your time.
Thank you so much. It was very informational, Dr. Harper. We do have some questions that have come in, but we also want to remind our audience that now is the time for questions. And feel free to submit your questions in the chat box below the video, and we'll get to as many as we can today. And these are in no particular order. Could long-term chiropractic work on the neck be harmful?
That's a good question. I don't know of any specific study that described if it's good or bad. It kind of depends on the veracity of the chiropractic work and the sort of aggressiveness of the adjustments.
Okay. Is chiropractic work something that you refer people to?
I will sometimes for people that just need hands-on treatment of the neck. I don't refer for the large or vigorous adjustments, but sometimes people do benefit from some of the neck traction things that chiropractors do, especially for the arm pain, because as you put traction on the neck, it does help relieve the pressure on the nerve at that area.
And how does that compare to a PT?
It tends to be, the hands-on work tends to be about the same, but the difference between chiropractic work and physical therapy is that physical therapy also gives you home exercises to do. So that's one of the reasons why we often recommend physical therapy as well, because there's a lot of homework, as you might say. In fact, physical therapy should be about 80% homework, which is in addition to doing the exercises in the clinic, the things that you're doing at home to work on your neck stretching.
Okay, thank you. As well as crystals in the ear canal, are neck and shoulder problems involved in vertigo? And if so, how are they treated?
That's a good question. There are neck issues that can cause vertigo. If it's vertigo where you feel the world spinning, it's not as common. There can be issues with the vertebral artery, which runs through the neck. If there's vertebral artery insufficiency, that's basically pinching of the artery that runs through the neck. That can cause symptoms of vertigo. There's a condition called cervical vertigo, which I've heard described. I've never actually seen or truly lend much credence to, where people describe neck pain, vertigo that's related to neck pain. Sometimes people might feel a little dizzy or woozy from neck pain itself. And then I've also seen if people have severe cervical stenosis or myelopathy, sometimes people, if you extend your neck, you make the spinal canal more narrow. Sometimes people do feel a little bit faint when they do extend their neck because they're compressing the spinal cord at that level.
Okay. What if the symptom is less a weakness, but instead is a shaking, particularly when pinching fingers and thumb together?
I would have to see that person. A lot of times pinching the thumb and the fingers together is a wrist or hand issue.
Okay. This person has a flat back syndrome subsequent to multiple vertebral fractures with the kyphoplasty.
Mm-hmm.
I believe as a result, with postural changes and challenges, my neck pain has increased with decline in mobility of neck. Any suggestions to relieve this?
Unfortunately, lots and lots of therapy. So flat back syndrome is basically where you get an adult deformity where your back is now flat, you have no lordosis to keep your head above your pelvis, and your head's now out here. Well, people that can't straighten their back because they have a flat back, they bend their knees and they tilt their hips, and their head's still sitting out front, so then they got to work all day to keep their neck straight. unfortunately, it's just going to require lots and lots of neck therapy and strengthening because you're working very hard to keep your head up all day long. And that's a compensatory mechanism that gets tired pretty easily.
Okay. Should the PT manipulation for cervical spine pain be excruciatingly painful? Because that's what this person is experiencing.
If they're having excruciating pain, they might want to stop the physical therapy for now and to talk it over with their physical therapist.
Okay. Can a pinched nerve in C1, C2 contribute to balance issues?
Cervical pinching can cause balance issues. Usually a pinched nerve at C1, C2 can cause headaches and eye pain.
What is the significance of loud popping sound from the cervical neck not associated with significant pain? These popping sounds can be heard by others in the room and can occur several times a day without any obvious trigger based on neck movement.
That's a common thing that I see in clinic as well. You know, as we talked about, there's a lot of shingle-like joints in the neck, and if any of those get arthritic, they can be noisy and loud because you're hearing bone-on-bone scraping. Also, you might be hearing basically what's a cracking joint, you know, sort of like you crack your knuckles, you might hear the cracking of your neck joints. And then sometimes people will feel snap, crackle, pop because of all those extensor muscles in the neck. You can hear those pop over the spinous processes and other muscles in the neck. And then actually bone conducts better than anything. So the mastoid and the proximity to your skull to your neck can often make the sounds of cracking and popping in your neck really be apparent to you. Usually if it's painless cracking, it's okay. It's usually just a measure of neck arthritis. But if it's getting serious, you might want to see somebody.
Okay. This person had some simple neck exercises recommended some years ago. They continue to do these daily. Are there any exercises you would recommend to strengthen the neck?
That's a good question. I don't have any specific exercises. I have some handouts in my clinic I can hand out to people.
Okay. This person cannot sleep on their right side. If they do, they get dizzy, see stars, feel like they have to throw up. It's like vertigo, but not exactly. Depending on how they move their neck, circulation gets cut off. They've had Botox and 2 pre-ablations. Those didn't work. Any relief that you can recommend?
Not without seeing you in person and taking some pictures. So if we can talk a little bit, if you want to come see me in clinic, I'm happy to take a look.
Okay, thank you. Do any of these spine compressions result in one side of the face, migraine or pain, eye, ear, jaw, eye, nose?
That's a good question. So technically the nerves that come out of the neck do run down the arm. Anecdotally, I've seen people get facial numbness, eye pain, because C1, C2, C3, C4, so the C2 nerve root, C1 nerve root, C3 nerve root can have pain that radiates behind the ear to the back of the head. And I've seen even with some cervical radiculopathy, people get some facial numbness.
Okay.
If you're experiencing those symptoms, you can come see me in clinic and we'll take some pictures and see if there's a neck origin.
Okay. This person had a ACDF, disc 4, 5, 6, 7, 10 years ago. Now they're having electric tingling from my neck to fingertips. Does this mean my discs 1 through 3 are now weak? And would x-rays help identify what's going on?
Yes, so I would come see me this week if it's getting bad, and we can get an x-ray and an MRI to make sure. I can see degenerative disc disease on an x-ray. I can see the status of the fusion, but the only way to look at nerves and spinal cord is through an MRI.
Is it serious, then you need to come in for this particular condition?
If they're starting to experience neurological symptoms, I would come see me soon, yeah.
Okay. This person has a couple of fused joints in their neck, as well as arthritis. No numbness or tingling in arms or hands. Is there treatment for that?
Yes, so for neck pain with facet arthritis with autofused joints, or if you're experiencing facet arthritis because there's additional pressure without any neurological symptoms, the radiofrequency ablation is a good procedure for that.
Okay. This person gets spasms, sort of like a Charlie horse, in both sides of their neck. Would surgery help?
It's difficult to say without seeing you and getting some imaging first.
Okay. We want to let our audience know we appreciate all questions, but the general questions are the most helpful.
Unfortunately, a lot of cervical spine questions are difficult for me to answer about your specific condition without seeing you and getting some pictures and imaging.
Thank you for answering the ones that you can.
Yeah.
Can you speak briefly about occipital neuralgia?
I wish I could. I don't know a ton about it, other than it's the posterior occipital nerve that can cause the symptoms. Generally, it's a physiatry or neurology will treat them.
It's a what?
Generally, a physiatrist or neurologist will treat them.
Okay. What PT exercises will relieve recurrent left-sided posterior muscle neck spasms, which seem to occur with stress?
That's pretty common. Usually just neck stretching to work on the posterior muscles in the neck, and actually usually stretching out the anterior muscles, believe it or not. My posterior shoulders and my trapezius get really tight. As soon as I started stretching out my pecs and some other muscles in the front, I found that often got better. It would be good I can get you in to see a physical therapist to work on some of those exercises.
Okay. This person gets weakness from their neck all the way down both arms to their hands. This is intermittent, but no pain. Do you know what condition this is?
Unfortunately, I don't, not without seeing you or examining you or getting some pictures, unfortunately. I would say if it's getting that way, I would see somebody sooner, or if it gets severe, go to the emergency room.
Okay. Can a C1 and C2 compression from athletic injury be fixed?
Yes, so C1, C2 arthritis can be pretty severe actually, and usually you feel pain right here around the level of the mastoid when you turn your head. And people with C1, C2 arthritis really have a difficult time turning their head right and left. The fix for that is to fuse it, so you can fuse C1 to C2.
So they do need to make an appointment with a spine specialist.
The person with
This person.
Yes, we'll leave the number for my clinic, and you can call in. I'm happy to see you in clinic, and we can take some pictures. Excuse me.
Are referrals needed in order to set up that appointment?
Generally not. It just depends on your insurance. Most insurance, you're okay to see us, as far as I know.
All right.
They'll tell you as soon as you call, and I believe there's a way to try to schedule an appointment at the end of the lecture.
Okay. To what extent does pain at the base of the skull contribute to lingering concussion symptoms in their right forehead?
That's a good question. I don't know much about the manifestations of concussion and or how that might relate to pain of the head.
Okay. Just 1 second, please. Does reverse lordosis in C6 and C7 need surgery? Gabapentin is no longer helping with pain.
It depends on what the symptoms are. If Just reversal of normal lordosis means usually disc space degeneration. If the symptoms are like the symptoms of radiculopathy with pain down the arms or myelopathy with gait disturbance and hand coordination issues, then that would likely need a surgery if conservative treatment is failing. Excuse me.
Do you recommend a particular bed pillow or sleeping position?
That's a great question. I get asked that a lot. I don't, and here's the reason why, is that everybody is so different. I know people that are only comfortable sleeping on their belly with their face on one side. I know people that can only sleep with their back in one direction. I will say the people that seem to be the most successful are the people that keep their head in plane with their neck, meaning like if you're laying on your side, your neck is basically straight this way, or if you're laying on your back, your neck is straight. That said, it's so variable for people.
Okay. This person has tingling when they turn their head to the right for too long. Is this something a PT could help with?
Potentially, I want to see them in clinic just to see what the manifestations are, but turning your head in one direction and getting tingling in the arm is a sign that one of the nerves is likely pinched.
This person is unable to have an MRI due to a clip for a cerebral aneurysm. What options are available to ascertain the actual issue in my neck and subsequent treatments?
There's a study called a CT myelogram where you inject dye into the spinal canal. You inject it, your spinal cord and your nerves are held in by a sac called the dura that encases it and is filled with fluid. You can inject that sac with dye and then take a CT scan, and that can show you similar things. That's what we used to do before they had MRIs.
So this person has finger tingling and weakness, and they do have some neck and shoulder pain. However, they were diagnosed with carpal tunnel syndrome. Should they get additional pictures for their neck?
It'd be worth looking at to see. If you have been diagnosed with carpal tunnel syndrome, certainly that can cause fingertip numbness. Cervical radiculopathy can do the same. It really depends on how the person was diagnosed with carpal tunnel syndrome. If it was diagnosed with an electromyogram or EMG or nerve conduction study, that's usually a pretty good way to see if there is carpal tunnel syndrome. That said, there's a condition called double crush where you can have cervical impingement and carpal tunnel syndrome, which can manifest with both. So the best way to differentiate the two is to get the EMG and then also get some imaging in the neck.
Are there any lifestyle changes that can slow the progression of disc degeneration?
That's another good question and something I get asked frequently. So the most important things are don't smoke, stay healthy, stay in good shape. I would say 90% of Boulderites have that down pat. You know, the unfortunate remainder of things tends to be either bad luck or bad genes or a combination of the two. And so if you were in the Delta Force, or if you were a rodeo rider, or if you were a parachuter, some of that stuff just causes additional pressure on the neck. Sometimes we're just born with bad necks or bad backs. Like that patient I showed you, some people have congenital stenosis. So other than doing the first three things, which is maintaining an active lifestyle, staying healthy, not smoking, eating a good diet, a lot of the stuff you can't help.
So this is one of those. This person had childhood scoliosis, and so, hang on here. Can it potentially cause C-spine problems later in life?
Sure, because it depends on what the curve was, if it was operated on and the magnitude of the curve. But usually when you have a scoliotic curve, an adolescent scoliotic curve, in most cases, there's a thoracic curve with a small compensatory lumbar curve, and then often an upper thoracic curve with a compensatory thoracic or cervical curve. So generally people that have some kind of, at least thoracic scoliosis, have some kind of scoliosis of the cervical spine.
Can straightening of normal cervical lordosis with a grade 1 spondylolisthesis of C2 on C3 after a head-on car crash be helped with surgery after other measures have failed?
I would want to see that person in clinic and get some pictures before I can comment on that.
This person is over a 4-week episode of significant neck and shoulder pain. It eventually became primarily in their left arm. The pain is gone. They do wake up every morning with non-painful tingling and numbness. Do you recommend that they get additional medical attention or just kind of wait and see?
It would be worth getting, coming to see us in clinic and getting a picture of it, and then potentially an MRI to see if there was nerve impingement, because there's some additional things you can do to see if it's getting better. And some additional treatments.
So, you've addressed some pain and a few things that can relieve pain, but sometimes when pain happens in your neck, it's immediate and it's spasms and it hurts a lot and it's hard to get relief and it's after hours. Should you have a muscle relaxer on hand? Or what is your recommendation to relieve the pain because you can't get your neck in any position that's going to relieve that pain?
I do have patients that have just neck spasm problems without any, nerve or cord impingement. And yeah, we give these patients muscle relaxers and exercises to do.
But if it's the first time and it's happening, what do you do?
Well, unfortunately, there's not a lot to do after hours other than go to an urgent care or an emergency department, unless you're already a patient.
And then what type of relief is typically administered there?
There's a few at the hospital. They'll often give you IV muscle relaxers or steroids or a few things that can help you relieve that pain, especially if it's really severe and you just can't move or get comfortable, or the pain is so severe you're having a hard time doing anything.
Okay. Does that help if the neck pain is triggering nausea as well?
Yes.
Okay. So hopefully that won't happen, but if it does, then go to the hospital and they can help you. Okay. Let me see here if there's any more questions, but we might be at the end here. Give me just 1 second, please. I think that's it for tonight. And we are just about at the end of our time here.
Thank you.
So we're going to go ahead and wrap up. We have come to the end of our time, and a recording of tonight's lecture is available at bch.org/livestream.